start with some general ED questions, I guess, before we get into some other injection therapy ones. This person wants to know what happens when a man becomes weary of self-injecting. Any tips to overcome the fear?
It depends. If you're saying weary, like you've never tried it before, versus weary, you've tried it and you really don't like it. A lot of men, come to me because Viagra stopped working, and I talk with them about the options. Some of them, as soon as I mention this, they say, "Okay, next option. I don't want to hear anymore about that." And I think it's just psychological, the idea of putting a needle into your penis and having to do that every time you want to have sex. That's the hardest part. The actual pain of it. I do have some patients that complain about it, but most people don't. So I'd say if you're sort of nervous about trying it, I would recommend giving it a try in the office with a doctor. And if it's horrible experience, you never want to do it again, then just don't do it again. But if you tried it and it doesn't seem that bad, then I would give it a try to use it in real life. Because if this doesn't work, there's vacuum devices and other things, but the next option is the penile implant, typically the inflatable penile implant, and I do those surgeries. We can talk more about that, but I typically have people at least consider this before moving on to that.
Alrighty. Next question here is to be our last general ED question before we go all injection therapy. But this person says, how common are ED problems to develop in a healthy male who is a non-smoker, non-drinker, with a healthy diet? And this happened to begin in his late 30s.
Late 30s, I would say, is uncommon to have severe ED, especially ED that doesn't respond to medications. I think most guys in their late 30s might say their erections aren't quite as strong as they were when they were 20 years old. Some of them might get some benefit from the Viagra, Cialis, but it's pretty rare for someone in their late 30s who has no other medical history to develop severe ED. As you get older, like by the time you're 50 years old, probably 50% of men have some degree of ED. Now, some of them, it may be mild, they may take some Viagra and they're good to go. Some of them more severe. So it definitely, the probability increases with age, even if you're perfectly healthy. But if you're in your late 30s, I'd be surprised if you're that healthy and the pills aren't working. It's certainly possible. And if that's the case, then definitely see your urologist and consider the other options.
Alrighty, we're going to hop into those injection therapy questions now. So first question here is, are the corpor cavernosa bodies interconnected? That is, does an injection on one side of the penis diffuse somehow to the other side as well?
Yes. The corpor cavernosa are fenestrated. So those two cylinders, they sort of share a wall, and that wall basically has holes in it. So yeah, you don't have to inject the medication on both sides. The medication goes to both sides, and that's true for anything. If somebody comes in with a priapism, an erection that's been up for days, and I want to inject the antidote, I don't have to inject it on both sides. Just inject it on one side. It goes to both.
Alrighty. Next question here. How do you end an erection after intercourse? Mine frequently last well beyond ejaculation, which can be inconvenient and embarrassing.
Interesting. I'm assuming that's a patient who's already been on the ICI. Most men don't have that issue after a regular intercourse. If that's happening after the ICI, you can try like exercise. Basically it's an issue of blood flow. So if you start doing some type of physically demanding exercise that requires blood to go elsewhere, it should shunt away from the penis. Ice packs can work. You can try actually masturbating and ejaculating again. All of those things will help bring the erection down. Obviously, if it's staying up after 4 hours, you got to go to the emergency room, and that's not just like doctor giving some warnings, that's pretty serious. We've seen people who wait a day or two, and then you have some serious long-term side effects of that.
Next question here. What is the cause of inconsistent results in the length of time the erection lasts while using the same dose of ICI medication?
Not totally sure. There's a lot of variables involved with an erection. Part of it can have to do with the nervous system, or basically your psychological component. So an erection is part of this. The nerves that control erections are not the same as the nerves that say control your hands, right? You can't just tell your penis to go up. It's part of this automatic nervous system. So the automatic nervous system basically has two components, the fight or flight component and the rest and digest component. And an erection actually is under the rest and digest component, which makes sense because if 1,000 years ago your ancestors saw a bear, that's not the time to get an erection. So your brain is wired, so anytime there's any sense of fear, anxiety, stress, shut down the erection and get the blood elsewhere. And sometimes we see that in men with their sexual encounters. They're nervous that they're not going to perform well. Maybe there's some relationship stress, performance anxiety, work stress. Any of these factors play a role. The penis isn't just a bag that fills with blood. It's connected to the nerves that go to your brain. So if you're really anxious about whether or not you're going to perform, whether you realize it or not, that's going to affect the quality of the erections. And some things are just, some days you can lift more weights than on other days. Your body's just not the same every day. A marathon runner doesn't always run the same time. Some days they perform better than others. So if you're having that issue that it's not lasting consistently, you might need to increase the dose. The other option is the penile rings that go along the base of the penis to help keep the blood in there. And part of it is sort of understanding the psychological component and trying to get rid of any stress or anxiety that you have about performance.
Alrighty. Next question here. Can a person who has failed a penile implant twice use injection therapy?
Not really. When you say failed a penile implant, that means that the implant was since removed. So then in that setting, the injections are likely not going to work because the penile implants, and we can do a separate talk about that later, basically go inside of the corpor cavernosum, and when they fill with the saline, they basically crush the natural spongy tissue that fills up with blood. So when you take one out, the expectation is that you're not going to be able to get a natural erection again. And that's part of the reason why we try to get people to try the injections before going to the implant, because obviously you can go from injection to implant, but you can't really go from implant to injection. So if you've had the implants before and they haven't worked, you likely need another implant to be able to have an erection again. And you might not need to go to just your average urologist. You probably need to go to a reconstructive urologist or somebody who's experienced with these revision cases, because average urologists might do a couple implants per year, but there's some of us that do multiple of them in a week. So you want to go to somebody with more experience for one of these complex cases. One disclaimer that I have to mention is I heard a story, I never saw this patient, of somebody who had a penile implant in and it was working, and on Valentine's Day or something, he wanted a little extra push, so he gave himself an injection, and without realizing it, made a small hole in his implant. And interestingly, it didn't present right away. It took several weeks before the implant sort of ran out of fluid. So don't do that. If you have an implant, you can't use the injections.
Alrighty. Next question here. Typically, how long should it take to get an erection after using the injections?
A couple minutes. It's pretty much automatic. It's not like the Viagra where you got to wait for it to kick in and still do the normal sexual stimulation stuff. It's automatic. We do them in the office, talking with the patient. The erection comes up within a minute or two. So there's no real wait time.
Alrighty. Next question here. Is it better to increase the strength of the formulation rather than increasing the volume of a lower strength formula?
That's a good question. On paper, obviously, it doesn't matter. It's just the total dose of the medication. And so it's really just up to you. Generally, I would say it's probably easier to increase the volume if you don't have any issues with injecting, just because it's a lot safer. You get a more precise dose, right? If I have let's say I'm doing 25 units here, and I want to increase it. I can just draw up more medication little by little. But if I have a stronger medication, then any sort of error in how much I draw up gets amplified. And these are such low volumes, even the most we have you put in at once is 1 milliliter or 1 cc, which is not a high enough volume that you're going to feel any different from the volume itself. I would say generally I would go with increasing the volume first.
Alrighty. Next question here. Once the dosage / formulation is determined that you're going to start with, do you provide and you get a prescription, I guess, from a patient's point of view? Does this require any ongoing clinic involvement?
Yeah, most clinics are going to want to have some type of follow-up. I mean, even if it's just a telephone visit before refilling the medication, and that could be really, really quick. Just, hey, this is working. I'm super happy. Can I get a refill? And once you're happy and you're everything is working well, you can probably ask to get more refills at once. But we generally don't have people just come in one time and never talk to us again and use the injections for life. It's not that we're trying to bill you for a clinic visit. We just want to touch base and make sure that everything is going well.
All right, certainly. Next question here, kind of along the similar lines. Must you see a doctor before you restart injection therapy after stopping it?
Probably. If you're going to see a new doctor, like if I've never met you before and you told me, I did this in the past and this was my dose, I would want to at least see you once in the office and before ordering the medication. That's pretty universal. Generally, the new patient visits are in person. I guess there's probably some places around the country where they have urologists doing entirely virtual clinics, but it gets a little dicey with different state lines and things like that. And we generally want to be treating patients who are close to us. So if there's a problem, they come to our emergency room, not somewhere on the other side of the country. But yeah, it's not that bad. Just come in for a quick 20-minute consult, and we'll get you back where you were.
So this next question here is just about quad mix, I guess. So you could just talk about, I guess, what the addition of atropine does into that mix.
It's basically just another medication that helps to open up the blood vessels. So if you're sort of maxed out on the other three, and you're really trying to avoid going to a penile implant, then we throw in basically a fourth medication, and we can titrate up the doses as well on that. So it's just another option to give you more of the medication essentially in a safe way.
Alrighty. Next question here is just asking to compare ICI injections versus intraurethral gel with respect to their effectiveness and risks.
Mm-hmm. I can say I don't have any patients that are using the intraurethral treatment. From what I've read, the ICI should be more effective, fewer side effects. The intraurethral gel or pill From what I've read, it causes quite a lot of pain and burning. And also there's neither of them really are very high risk in terms of something that's going to get you sick or in the emergency room. It's more just at what point do you develop pain or other symptoms versus the effect of getting the erection. So either one is fine. They're both on the official urology guidelines as an option, as well as the vacuum erection device with the penile ring. Those are all sort of in the same tier between the pills and the implant. So all of them are totally safe. Actually, the vacuum is probably the safest because there's no drugs involved. But between the injections and the intraurethral suppositories, it's just a matter of the side effects. So you can try a low dose of the intraurethral suppository and see if that works. But I generally don't even bring it up with patients because people, from what I've read, don't tend to like it.
Alrighty. Next question here. Will injection therapy help with my venous leakage problem?
On paper, no. On paper, if the problem is a venous leak, these medications only work to increase the blood supply. Now, it gets a little bit complicated because the only way that you sort of know that you have a venous leak, generally speaking, is to do the injections and then do what's called a Doppler ultrasound, basically an ultrasound of the penis after the injection has been given. But if you've already given the injection, then you can just ask yourself if it worked or not. And there's not really that much benefit to the ultrasound. So you got the injection and you didn't get an erection, then the injection didn't work. And you can try increasing the dose, but you sort of have your answer. So it's a little bit more this whole distinction between whether you have a venous leak or arterial insufficiency is somewhat academic. Basically, if the injection's not working, even at the max dose, then the only option left is a penile implant, and that will work whether there's a venous leak or arterial insufficiency. The only thing that's thought to maybe help with the venous leak would be the penile ring that goes around the base of the penis, but that's not that effective.
Alrighty. And a little bit of a follow-up to that, is there any specific blood vessel or valve that is responsible for the leakage in terms of addressing this, or is it just a general blood flow problem?
It's just a general blood flow problem. There's no like one specific venous valve that is leaking. There's hundreds of veins throughout the penis, and there's no real way to fix this. There's no vein surgery for this. So the natural sort of valve that we have in the penis is the arteries filling up with blood and sort of squeezing off the veins. So in theory, increasing the arterial blood supply with the injections should help with that. And the penile ring also helps with that. But no, we don't have any specific therapies designed to address the venous leak. And I don't almost never, I won't say never because I have done some, do a penile ultrasound in the office to diagnose a venous leak.
Alrighty. Next question here. Can the ICI treatment cause penis shrinkage?
It shouldn't. Most men don't complain about that, but it is possible. So in men who have Peyronie's disease, which is where they basically develop curvature of the penis because of scar tissue, I typically don't recommend the ICI injections because they're prone to forming this scar tissue from micro trauma. So you've probably seen those commercials of the bent carrot. That's the Peyronie's disease. So in theory, even if you don't have Peyronie's disease and you start doing a lot of ICI, in theory you could develop Peyronie's disease from the injections, and that could cause curvature or shrinkage. But 99% of men don't have that problem with the ICI, with the sort of note that we generally don't start people on ICI if they already have a history of Peyronie's disease.
Alrighty. Next question here. I'm curious about what components of trimix are most likely to cause a priapism.
It's all of them. So all of these medications basically work on the blood vessels in the penis to cause them to dilate. So there's no one component or the other. It's just the overall dose. And just want to reiterate, the risk of developing a priapism from ICI is very, very low if it's done in the proper setting. I've never actually seen it. Every time, I've dealt with a lot of priapism between residency and in practice. It's always somebody who injected themselves with more dose, or they took some other drug, or they have some other medical condition that caused it. And in terms of priapism, just while we're on the subject, if somebody does come in and the erection has only been up for 4 hours or so, we have an antidote that will make it go down right away, and it's not that big of a deal. There's no long-term consequences of that. The problem is a lot of guys don't want to come in to the ER because they're embarrassed or whatever. They wait a day or two, and that's when it's a real problem. It's hard to get it down, no pun intended, and it is going to have some long-term side effects. So I wouldn't worry too much about priapism if you're doing the ICI the recommended way. It shouldn't happen, and if it does happen, if you come in right away, we can get it fixed.
Alrighty. Next question here, does alcohol affect the effectiveness of penile injections?
Low dose, if you're having a beer or two or a glass of wine or two, it's not going to be an issue. If you're getting like totally trashed, then you might not be able to get an erection. That's whiskey dick is real. But if you're that drunk, you're probably not even going to be handling the needle appropriately. And some people actually note some benefit to having a drink or two, because it can sort of relax your brain a little bit and deal with some of that automatic nervous system stuff that we talked about. People having anxiety and stress, and that causing them to lose their erections. So it's not a contraindication. You can have a drink or two and still do the injections, and it's not going to affect it in terms of the efficacy, unless you're really pounding back drinks aggressively.
Alrighty. Next list of questions is going to be some injection technique questions. So first one here, this person needs better guidance on their location. They have foreskin, and they want to know if they need to pull it back before the injection.
No, you don't need to pull the foreskin back, because the foreskin just goes over the head of the penis or the glans penis. You don't want to put any needles in here. This is a separate anatomic structure than the corpor cavernosa. So that shouldn't be an issue. You can have foreskin going over the penis, and you can put the needle through your penile skin just like a circumcised man would, and that won't be an issue.
Alrighty. Next question here. This person says they have problems with the needles bending, and they want to know if there's any device that can prevent this.
Needles bending. I haven't heard that one before. I suspect that this thing might help. This what is this called? The 𝐒𝐿𝐷. It's a product that MenMD sells that helps make it a little bit easier to inject. But if you're injecting the needle head on, you're coming in at a perpendicular angle to the skin, it shouldn't really bend. Maybe torquing it a little bit, and that might be causing slight bending. I want to talk with this person a little bit more to see, how bent we're really talking. Are they using a tiny needle like this? Because it'd be pretty hard to bend this. I'll try it. This guy. Yeah, I mean, this tiny needle, doesn't have a lot of length to it, so there's not a lot of torque to bend on. And this penis, which is actually somewhat structurally similar to a usual flaccid penis, I'm not able to get it to bend. So you maybe, it actually just sort of tears through the penis. You maybe need to adjust your needle, would be my guess. You want to have a short needle would probably be the key, and making sure that you're going in, perpendicular to the skin, right there, and then it really shouldn't bend. But if you're having that issue, I don't know if you live near Long Island, if that's something you want to talk with me about, or talk with your urologist about, and they can sort of maybe do a dry run with you in the office to see what you're doing and see what's causing this.
Alrighty. I guess a follow-up to that question is it possible to bend the needle on the vial itself when they're maybe drawing up the medication? That is a question we have here.
Oh, let's see. So it shouldn't. Like when you put it in the vial, it just sort of goes right in at a 90-degree angle. I'm going to try it here. I've never done this before to bend it. Yeah, you can bend the needle, but I feel like that would have to be intentional. Yeah, and if that did happen to you, just throw that needle away and get another one. But it does, and you would be able to look at the needle before you put it in your penis. But if you rest, you don't need to be a microsurgeon to be able to put this in at a 90-degree angle. You can have somebody hold the vial for you even, and you just push it in. Well, this needle's already bent because I bent it. You just push it in, and there shouldn't be any issue with the needle bending. And if you need, reteaching, just go see your urologist and see what could be the issue. Yeah, this needle, once it's bent, it's hard to get it to be straight again. So I wouldn't mess around with bent needles. Just throw it out and get a fresh one.
Certainly. Alrighty. Next injection technique question here. This person wants to know if standing, if there's any benefit to this while injecting.
No, not unless it's like helping you in some way see what you're doing. But in terms of the blood flow, it doesn't really matter. Standing, sitting. I hear people say all sorts of different stuff. Oh, it only works if I'm standing, or it only works if I'm sitting or laying. There's no real explanation that I can have for why that would be. I would just say whatever is the easiest way for you to get the medication in yourself, do that.
Alrighty. Next question here. Is it common to have consistently better response to injection on one side of the penis or the other?
No, that's not common, but I suppose it's possible, especially if you have some type of Peyronie's disease or scar tissue on one side of the penis. The other side would likely work better. But in theory, it should be the same. Any medication you inject on one side should get to the other side within seconds. If that's the case, if you have one side that's good or one spot that's good, yeah, if you have one side that's good or one spot that's good, just use whatever side that is. But generally, it should be fine either way.
Alrighty. Next question here. How many hours must we wait between trimix injection here?
Yeah, so 24 hours between injections, and generally not more than 3 or 4 times per week. But definitely wouldn't do it twice in a day.
Next question here is this person wants to know what the best way is to insert the needle when his belly keeps him from seeing down there.
That could be a little bit tricky. I'd say ideally if you have your partner help you. I understand that's not always possible. Probably laying down, your belly would sort of be out of the way as much as possible. But then it's going to be a lot of tactile, right? Just what we call proprioception in neurology. Basically feeling the penis, feeling the spot that you want to inject it, maybe pinch that spot, and then sort of just with the tactile feedback, be able to guide your needle to that spot. Most neurologically intact people should be able to do that, but it could be a little tricky. That would be my recommendation, is try to, pick the spot, maybe pinch that spot so you can brain sort of recognize that's where it is, and then sort of guide your needle to that spot. It would probably take some practice, but I think it wouldn't be that hard to do.
Also have some feedback in the chat from someone who is in a similar position. They say that they use their wall mirror to help them assist the process.
That's someone smarter than me. I didn't think of that. Yeah, that would work. A wall mirror would help you see what you're doing.
Alrighty, and just to move along to the next question, this came up a few times, but if there's any sort of injection site pain, what is the best way to avoid and/or relieve this?
Ice can help. Ibuprofen would probably be the best medication to help, but ibuprofen is going to take a while to kick in. Same with Tylenol can help. Ibuprofen would probably be better. The other option, I've never had to have a patient use this, but there's topical anesthetics, I believe it's called 𝐉𝐨 cream. It's just a cream with lidocaine in it. I believe it's mainly used for patients with hemorrhoids, but it works well. Basically, a cream that you could put on your penis to numb that site, so you have less pain there. Obviously, you don't want to numb your entire penis, otherwise you're not going to feel the sex. Some people actually do use topical anesthetics for sex to deal with premature ejaculation, but that's sort of a different topic.
Next question here. How do I stop bleeding at the injection site?
It's mainly going to be pressure. So I'm assuming you've already tried that, but you just hold more pressure, harder pressure and for longer, basically, will get the bleeding to stop. And what we see sometimes is, people hold pressure for 30 seconds, they get impatient and they check, and it's still bleeding. Hold pressure again for 30 seconds. I would say, hold the pressure as hard as you can and keep that pressure there, especially if you're somebody who has this problem. Maybe set a timer, like 5 minutes of hard pressure. I'd be surprised if that tiny needle spot is still bleeding if you don't have a bleeding disorder. This is, sort of off topic, but a common consult, that somebody has, bleeding from an incision and the ER can't get it to stop, and send an intern down there and tell them hold pressure on that spot for 30 minutes and then call me if there's a problem, and they never call. And so the problem is not holding pressure, one, either hard enough, or two, long enough. But it's a tiny needle, so there's no reason that should not clot if there's no bleeding disorder.
I'm going to move along to a new group of questions about injection therapy with other conditions. So this person wants to know if this procedure would work with BPH and which should be treated first, the ED or the BPH.
Yeah, the BPH is sort of an entirely different disease, and so it wouldn't have any effect one way or the other. I would say to treat them both simultaneously, just because they both can have a major effect on quality of life, but either order would work well. The only time, with BPH, the things that you need to think about in terms of sexual function, the most common medication used for BPH is tamsulosin or Flomax, and that shouldn't cause any issues with erections, but it does typically cause what's called retrograde ejaculation, meaning that when you have an orgasm, everything feels the same, but nothing really comes out, which is fine. It's not dangerous unless you're trying to have kids or something, but just something to be aware of. The other medication commonly used for BPH is finasteride, which works to shrink the prostate. Some men report that finasteride can decrease their libido and decrease their erections. Obviously, if you're having that, you might want to stop that medication, but most men don't have any side effects from finasteride. And then the other one that has some crossover is actually the Cialis, tadalafil. Low dose tadalafil, the 5 milligrams per day, is commonly used for erectile dysfunction, and it has been shown that actually helps men with their BPH symptoms. We don't really understand exactly why that is, maybe better blood flow to the prostate, but a lot of men take the Cialis 5 milligrams a day, and that helps with their ED and their BPH.
Next question here, does injection therapy affect high blood pressure and/or someone that is on blood thinners?
So sort of separate questions. The blood thinners does not have any effect on the erections. The only potential issue is the bleeding from the injection site, but it is not a contraindication, meaning you can still do the injections if you are on blood thinners. You just need to hold pressure for a little harder and a little bit longer, and you are at a slightly higher risk of developing bruising or hematoma, something like that. In terms of the elevated blood pressure, you should make sure that that's controlled with your blood pressure medications. But again, that's not a contraindication. These medications for the erections, the ICI, should lower your blood pressure, but it doesn't really do that to any major extent. It mainly just stays in the penis. So that's not an issue. You can take your blood pressure medicines and do the penile injections. Thanks for watching. Please like, comment, and subscribe.